Hi, good morning, everyone. Thanks, Lee May. It's my honor to be able to present the J.J. Zhang Gynonc Lectureship today. Our very own Dr. Swanson will be talking with you. J.J. was we'll get her picture up there. Thanks, Kevin. J.J. was a beloved mother, wife, sibling, and friend who took care of her loved ones with humor, sacrifice, and unconditional love. She was my patient and was cared for by many of my partners and colleagues. She had grace, courage, and resilience and was beloved by her family and by her UCSF gynecologic oncology team. Her family chose to honor JJ by funding this memorial lectureship. We are so grateful for this gift and will forever hold JJ's beautiful spirit in our hearts. I'll turn it back over to Dr. Chen for an introduction for Dr. Swanson. Thanks for being here, everybody.
Thank you very much, Dr. Chapman. We wanted to thank Ms. Zhang and her family. I have the pleasure of introducing today's speaker for the J.J. Zhang lecture, and that is our own beloved Dr. Megan Swanson. Dr. Swanson is an assistant professor in the Division of GYN Oncology in our department. Many of you may remember Dr. Swanson when she was a trainee here, as she did her residency and fellowship, and as Dr. Chapman knows, we keep our best. So Dr. Swanson joined us on faculty and has a strong interest in cervical cancer prevention and early detection, and also works in our dysplasia clinic, which is our pre-cancer clinic for cervical disease. We thought that she was an excellent candidate to speak to us on cancer prevention. And now we have different opportunities of being able to prevent our different types of gynecologic cancers. So I'm really excited to hear Dr. Swanson's talk today. We have about 20 minutes and then some time for Q&A. So please line it up, and we look forward to hearing from Dr. Megan Swanson. Thank you.
Thank you, Dr. Chen. I really appreciate that introduction. And thanks to Dr. Chapman. I have shared my screen. When I did that before, the slides started just going on auto, which I have not encountered before. So let's try that again, and hopefully we'll have a better outcome. But thank you so much. I am also honored to be presenting this as the J.J. Zhang lecturer. When I was a fellow, I took care of JJ and I remember her quite fondly. So thank you so much for that. Let me try to do my slide share in a way that will not put these on auto. We'll give that a try. So I was asked to speak about prevention of gynecologic malignancies today, which is a topic close to my heart. I have a specific interest in public health and happy to go through this and talk about it. We'll move through specifically about cervical cancer, ovarian cancer, and endometrial cancer, and then I will leave some time for questions. So we won't be talking about vulvar cancer, vaginal cancer, which are more rare today. And for the uterine cancer, we'll focus specifically on endometrial cancer. We'll start with cervical cancer. There are many opportunities for prevention and early detection of cervical cancer. This is HPV, which is the virus that causes the majority of cervical cancer. Risk factors for cervical cancer, first and foremost, include HPV infection, lack of HPV vaccination, cervical dysplasia, which is by and large caused by HPV infection. Cigarette smoking is also an independent risk factor, as are conditions which reduce our body's immune response, like HIV and other immunosuppressive conditions, or medications that some of our patients have to take for things like autoimmune disorders, things like steroids. Putting risk into perspective, HPV really causes the majority of almost all cervical cancers, and specifically HPV types 16 and 18 cause more than 70% of all cervical cancers. If we often think about risk factors for cancer, we think about cigarette smoking. When you think about cigarette smoking in the context of lung cancer, we're looking at an increased risk of about 10 to 20 from a smoker to a non-smoker. When we're thinking about risk for cervical cancer with somebody with HPV 16 positivity versus negative, we're looking at a factor of over 400 times more likely to develop a cervical cancer. So this is really, by and large, the main risk that we're seeing with cervical cancer is HPV infection, and specifically HPV 16, which is probably the most high-risk type of HPV. HPV is also the key to prevention, primary prevention with vaccination, and secondary prevention with screening. I'll first address primary prevention with vaccination. There are 3 different vaccines that are on the market, and they've kind of gone through chronologically. First, a bivalent vaccine specifically providing protection to HPV 16 and 18. Then a quadrivalent vaccine was developed. And now the vaccine that by and large is used in the United States and mostly around the world is the 9-valent Gardasil 9 vaccine. Vaccination is incredibly effective. It's recommended, the CDC recommends that we start vaccination quite early. We recommend, sorry, I'm having trouble with my slides. We recommend vaccination start really at age 9. So really the target should be all boys and girls between 9 and 12. For those individuals between 13 and up to 26 who have not previously started vaccination, the WHO and the CDC recommend catch-up vaccination, which means basically just starting at that time. It's more effective when given before the onset of any sexual activity. Unfortunately, and not surprisingly, HPV vaccination rates in the US are really low. We're really only looking at about 50% of eligible people in the United States have gotten this vaccine. This vaccine is a cancer preventing vaccine, and there's really very little risk to getting the vaccine. You can see it does vary state by state. The light blue are kind of the least covered states, and the orange is the most covered. So there's some variability state by state, but by and large, we really haven't as a country picked up HPV vaccination. So this is the #1 thing that can help prevent cervical cancer is HPV vaccination. It's incredibly effective, nearly 100% effective if given before any exposure to the HPV virus, basically. So looking at really approaching 100% efficacy in the big studies, the big cohort studies that have looked at this. Secondary prevention is also possible. There's a precursor lesion called dysplasia, which means abnormal growth, and that can be picked up with things like Pap smears and HPV testing. So because of the way HPV works, it makes 2 different proteins which limit our cell's ability to kind of put the brakes on cell growth. That process takes a while, and so it can be caught early and intervened upon. So not only primary prevention, but if somebody, let's say, didn't get the vaccine and starts to develop the precursor lesions that can lead to cervical cancer, things like Pap smears and HPV testing can hopefully pick that up before progression to cancer, which is what this pictorial chart is showing. Can help identify and prevent cervical cancer, even for those that weren't vaccinated. But strongly recommend vaccination. #1 thing we can do to prevent cervical cancer and all around the world. The WHO actually has a initiative to prevent cervical cancer worldwide. They have I don't have a slide about this, but there's a 90-70-90 paradigm, which the goal is 90% of the entire world vaccinated, 70% at least one-time screening, and 90% of those with cervical cancer in treatment. Basically, if that's been mathematically modeled, if those numbers are met, we're falling sorely behind that in the United States with only 50% vaccination. By getting to 90%, we could theoretically almost do away with cervical cancer in 100 years. So there's definitely opportunity. Ovarian cancer. This is a picture Dr. Chapman sent to me, and this is some of us actually operating. We think largely about ovarian cancer as a surgical disease, and one that's found at a fairly advanced stage. The surgeries we do and the chemotherapies we give are often to treat advanced ovarian cancer. Ovarian cancer is curable when we catch it at an early stage. The green people here are people who are alive at 5 years. So we call it 5-year overall survival. At stage 1, we're looking at 85 to 90% of people are alive at that 5-year mark. And we're looking, unfortunately, when ovarian cancer is diagnosed in a later stage, like stage 4, we're looking at really only about 20-25% of people, unfortunately still alive at that 5-year mark. So we know that if we can detect and diagnose ovarian cancer at an early stage, we're able to cure it. So in order to shift that paradigm, we need to be able to do that. Unfortunately, ovarian cancer does not cause symptoms usually when it's in that early stage confined to the ovary or fallopian tube. So we need to find a way, if we're going to prevent and detect early cancers, we need to find a way to find a precursor lesion and identify those who have that before it becomes a cancer, or certainly before it spreads out of the ovary to other parts of the body. All cancer is basically genetic on some level. Some of those, like on a molecular level, there's always something at a cellular level that has kind of gone awry and has led to the formation of a tumor and the formation of a cancer. Sometimes those genetic changes are inherited mutations. And that's what, when we talk about, cancer as a genetic disease, that's where most people's mind goes, is thinking about inherited mutations. Mutations can also happen on the cellular level because of an exposure to, let's say cigarette smoking or something like that. In the case of lung cancer, with cervical cancer and HPV, it's the HPV is the exposure that causes the molecular changes that lead to the cervical cancer. These molecular changes can also be sporadic, kind of thought of as bad luck. We often call that, and you guys might have heard us in visits call those somatic mutations. But ovarian cancer, epithelial ovarian cancer, is often caused by an inherited genetic mutation. So this we see all women in the general population, the lifetime risk of epithelial ovarian cancer is about 1 in 70. So it's about a 1.2, 1.3% lifetime risk. But for women with inherited germline BRCA1 or 2 mutations, that risk is up to 20 to 40% in one's lifetime. Now, BRCA2 mutation carriers are only about 1% of our population, but this is a specific group of people that have an increased risk. And we've learned about the formation of ovarian cancer from this population. And that has led to scientists and clinicians thinking about how we could potentially screen for ovarian cancer. Screening for ovarian cancer is challenging, mostly because ovarian cancer is so rare. When a cancer is quite rare, we need a test that is not only sensitive, meaning it'll pick up all cases of ovarian cancer, we also need it to be specific, which means it's not going to lead to many false negatives, okay? And that is a huge challenge when a cancer is rare, okay? So we've learned from BRCA mutation carriers, we've learned this from analyzing the fallopian tubes and ovaries when we do risk-reducing surgeries. We've learned that probably, and the pathologists have been really helpful in developing this theory, that there probably is a precursor lesion to some epithelial ovarian cancers, and that starts in the fallopian tubes and is actually microscopic. You might have heard this referred to as a STIC, S-T-I-C, serous tubal intraepithelial carcinoma. But this is the prevailing thought, that most epithelial ovarian cancer probably does start in the ovary. So that has led people like my colleague, Dr. Chapman, who's a leader in this field, to think about, well, if we know that this starts in the fallopian tube, can we find those molecular changes in the tube? And is there anything circulating in someone's blood? Can we see on a serum test before anything even develops or can be seen on ultrasound? Could we pick this up? And this has led Dr. Chapman to developed this study called the PRECISE study, Prediction with Circulating Tumor DNA to Screen for Epithelial Ovarian Cancer. And some of you might be familiar with her work. And some of you might have even participated in this project. She has an ongoing project at UCSF to try to identify what are these molecular changes in the fallopian tube, and can we pick them up on a blood test, a serum test. So more to come. Other risk factors for ovarian cancer, endometriosis is another risk factor, completely separate from, well, we think probably completely separate from inherited genetic mutations. There may be something that we don't yet understand about endometriosis, but we don't know of any, to my knowledge at least, we don't know of any germline factors that are causing that. Hormone replacement after menopause, estrogen and progesterone, it is related to the amount of time someone's been on it. This is a much smaller magnitude, but there's pretty good evidence that this is related to epithelial ovarian cancer. And obesity and height, also much lower magnitude of association, and we don't know why, but from epidemiologic studies, we have seen that association. There are some factors that are associated with a decreased risk of ovarian cancer. We know that oral contraceptive pills and the duration that someone has been on oral contraceptive pills is related to the magnitude of that decrease in risk. We know that tubal ligation, about a 30% lower risk, salpingectomy, bilateral salpingectomy, removing the fallopian tubes, up to a 50% decrease in risk. Having had children, we call that multiparity, can be up to a 30% lower risk, and breastfeeding and the amount of time someone has breastfed. And while it sounds amazing, things like 30% drop in risk, because ovarian cancer is so rare, really only about 1.2%. If you do the math, which is basically the inverse of the difference of risk there, you'd have to have about 250 to about 300 people have a tubal ligation to see one fewer case of ovarian cancer. So even though we see something like 30% decrease in risk, because this is such a rare cancer, still need a lot of people to have that intervention to prevent one case. Because you might say, well, why doesn't everybody have a tubal? It's just that's kind of the reality of it. But we do see that risk reduction, which is fantastic. BRCA1 and 2 mutation carriers, and Dr. Chen has done a lot of work here to help kind of figure this out, and she's a leader in the field here. We know that there's an opportunity for risk reduction here by removing the ovaries and fallopian tubes. And we see this is just a picture of a uterus, and I've circled the ovary and fallopian tube, doing a risk-reducing bilateral salpingo oophorectomy, removing both ovaries and tubes, for BRCA1 and 2 carriers can decrease the risk of ovarian, fallopian tube, and primary peritoneal cancer by 90%. Now you might say, well, why isn't that 100%? That doesn't make any sense. We remove the ovaries and fallopian tubes. We can't ever in medicine reduce the risk to zero for anything. We wish we could, of course. But there is a risk of something we call primary peritoneal cancer, which is potentially still related to that process that starts in the fallopian tube, but potentially those cells have dropped off the fallopian tube and seeded the peritoneum in a microscopic way before we can even do the surgery. So we can't ever get to zero, but significant risk reduction, 90% risk reduction with this surgery. And that's how we've learned doing these surgeries. That's how the pathologists have found these precursor lesions in the fallopian tubes and have led to research efforts such as what I discussed that Dr. Chapman is carrying out. So you might say, well, if it starts in the fallopian tube, why can't we just take out the tubes? Wouldn't that do the trick? Maybe. We don't know. That's an area of active investigation. The good thing about, just taking out the tubes or doing a risk-reducing procedure for BRCA1 and 2 carriers where the fallopian tubes would be removed either only or first in a staged approach is that you would avoid menopause symptoms. It's the ovary itself that makes hormone, not the uterus, not the fallopian tube. So we'll find out. It's an area of active research at this point. I'll finish with endometrial cancer. So endometrial cancer is the cancer that happens in the endometrium, the center of the uterus. People call it the lining of the uterus. It's the glandular cells, not the muscle cells on the outside of the uterus, but the glandular cells inside. Risk factors for low-grade grade 1 or 2 endometrial cancer have to do with estrogen. This cancer is caused by a relative increase in excess estrogen without a balance of progesterone. Estrogen has the effect on the endometrium. This is an MRI picture, a sideways picture of somebody. This is the uterus with the arrows pointing to that enlarged area there. That's a growing endometrium. That should just look like a little line. In this person, you see it's kind of thick there. Estrogen causes that increase in growth, which over time can lead to a cancer. The excess estrogen can be what we call exogenous, things like hormone replacement therapy, or tamoxifen, which is a drug that's helpful for breast cancer. It limits estrogen effect in the breast, but actually increases estrogen effect in the uterus. So hormone replacement therapy, tamoxifen, or endogenous, meaning something that happens in our own bodies. Chronic anovulation, polycystic ovarian syndrome, or obesity. Obesity lends itself to a situation where there's more adiposity in the body, and fat cells peripherally convert steroid hormones that circulate in our bodies into estrogen. So increased adiposity, more fat cells in the body can actually increase the total amount of estrogen the body's exposed to. There's also a genetic syndrome called Lynch syndrome. Dr. Chen's also been a leader in developing some of the guidelines for risk reduction in people with Lynch syndrome that can lead to ovarian cancer in a different pathway. It's a germline mutation, an inherited mutation in the mismatch repair genes can lead to endometrial cancer. If somebody has Lynch syndrome, which is a rare type of syndrome, there can be up to a 50% lifetime risk of uterine cancer. We usually think about colon cancers as the main risk associated with Lynch syndrome, but for women with a uterus, uterine cancer is actually just as common often as colon cancer. So strategies for prevention. This talk is about prevention. For Lynch syndrome, which we just talked about, birth control pills, and then a risk-reducing hysterectomy after completion of childbearing is the recommendation there. And then for women who are on tamoxifen, which is an important life-saving medication for breast cancer, researchers wonder, could a levonorgestrel IUD, a Mirena IUD that essentially has progestin, could that help? Could that be safe, for women with progesterone receptor positive breast cancer? These are unanswered questions, but potentially. For polycystic ovarian cancer, potentially birth control pills, which have the estrogen and the progesterone. And for obesity, weight reduction, lifestyle modifications, or even bariatric surgery. There are some studies that have shown a decreased risk of endometrial cancer as much as 50 to 80% actually with bariatric surgery. So just throwing that out there, that can be a significant cancer reducing risk. And I would like to end with just pointing out that we actually see racial disparities in all of our cancers, but this is particularly poignant in endometrial cancer. We see Black women are disproportionately affected by endometrial cancer in the United States specifically. Compared to white women, Black women have an increased incidence, meaning just kind of percentage of endometrial cancer, and a higher incidence of aggressive endometrial cancers, not the grade 1, grade 2 estrogen dependent ones, but the clear cell, serous, carcinosarcoma, and high grade endometrioid. And the Black women have a higher, basically 5-fold mortality risk compared to white women for nearly every stage and subtype of endometrial cancer. We do not understand why this is, but we know that it's not genetic differences that vary by race. I have here a picture of the public health critical race praxis. This is a conceptual model and something that we in public health have used for many different diseases. This is not specific to endometrial cancer, but to try to understand why Black women or Black people in the United States have disparate outcomes. And so this takes into account many different factors, but they all stem from racism that exists in the United States, basically. So if you look here, this is just to highlight the complexities here that lead to differential, disparate outcomes for our patients that we would like to eliminate. So working towards justice, anti-racism, and equity could actually lead to improved health outcomes in our patients. So that's what we all are striving for. This is some of the work of a doctor in Seattle. Her name's Kemi Dahl. This is just taken from one of her papers to show the complex interplay here. But I'd just like to end with that for some reflection. And then I'm, of course, happy to take questions about any of it.
Thank you so much, Dr. Swanson. I think we wanted to start off today in our symposium with discussion about prevention, because when we are treating cancer, especially with advanced disease, it becomes increasingly difficult with more high-risk disease. And I think you've highlighted some ways that we can work on preventing and detecting these cancers earlier. There is a question in the Q&A that relates to cancer risk. I'm going to ask and see what your thoughts are. Can extensive scarring inside and outside the fallopian tubes from undiagnosed PID cause an increased risk of ovarian cancer?
That's a great question. And that is something that people have looked at to see if pelvic inflammatory disease and inflammation in general is a risk factor for ovarian cancer. And we have not seen that, at least epidemiologically, we have not seen that association borne out in the literature. So I would say at this time, the literature would say, no, we don't see that as a risk factor for ovarian cancer, but great question.
Any other questions? People can put them in the chat. Dr. Swanson, can you explain a little bit more about ovarian cancer risk factors related to height? I've heard about obesity, but not height before.
Yeah, it's a great question. I can't explain it, actually. It's something that we call an epidemiologic association. So when researchers, epidemiologists have looked at large cohorts of people and have tried to look at myriad factors, things like cigarette smoking, height, age. Well, we do know that increased age is associated with ovarian cancer, but things, myriad different factors. For some reason, increase in height seems to be associated with a higher risk of ovarian cancer. We do not know why. I cannot explain that on a genetic level, but we do see the association in epidemiology.
Right.
We're talking a very small association here.
I know, because we talk about BMI, but
yes, exactly. BMI, we do see as a risk, and BMI takes height into consideration almost in an inverse type of way. But it's BMI and height for whatever reason does seem to be associated. We can't necessarily explain that at this point, but we do see the association.
Let's see. There's a question about association of hair relaxants with endometrial cancer risk. Can you speak to that at all?
I don't know. I'm not an expert on the different exposures in endometrial cancer. People have looked at things like hair dye and relaxers and things like that. I don't know the magnitude of those associations, but potentially different chemicals that we are exposed to potentially could be related to a cancer. I think we need to do a lot more work to kind of look at those associations in larger studies.
And there's a question about Lynch syndrome, and Lynch syndrome is a cause of endometrial cancer. So is the Lynch syndrome a cause of endometrial cancer because of colon cancer in one's family? This individual's father died from colon cancer.
Great question. So colon cancer can be a sign that potentially there's an inherited mutation that led to that colon cancer, and that would be the Lynch syndrome. If that is present, and that's not going to be for the majority of colon cancers or the majority of endometrial cancers, but if that mutation happens to be present in one's family, and maybe that was the reason that led to the colon cancer, then it might be that same risk could lead to uterine cancers. But it's not like having the colon cancer in and of itself increases a risk for uterine cancer. It would be the colon cancer might be a signal to talk to a genetic counselor about maybe exploring testing And then maybe if that was there, then maybe there's a risk for uterine cancer.
And I would comment that all colon cancer pathology biopsies should be screened for
Yes.
Lynch syndrome. And currently, all endometrial cancer of the lining of the uterus biopsies or hysterectomy specimens should also be screened for Lynch syndrome. So that association is present. And if Lynch syndrome is found, then that might increase a family's risk for endometrial and or colon cancer.
Yeah, definitely. And while it's a small percent of any given uterine cancer or colon cancer, we would never want to miss that association, because anything we can do to decrease one's risk of other cancers, we as clinicians want to know about and want to take steps and precautions.
Dr. Swanson, we're going to wind down, but I appreciate you talking about disparities. There's actually a question that relates, maybe we can tap in your public health background, about studies that go down to a heritage level. So rather than a broad demographic of Black, white, Asian, how are we looking at South Asian, East Asian, Western European, African origin for demographics of thinking about cancer risk?
Well, with that last slide that I put up, that was the public health race praxis, that's the conceptual model to think about risk of cancer. That's not exactly looking specifically at breaking down further the inheritance pattern, which might have something to do with genetics. That's more looking at what does it mean to live in a society with the particular social constructs that we see in the United States. And if someone is perceived as Black versus white versus Asian versus South Asian, how is that social climate impacting one's health, impacting one's ability to access care, impacting the different stress levels and hormone levels that might be in someone's body. So that was more of a social construct and not so much on a granular kind of inheritance pattern. So I guess I'll just that's kind of a politician non-answer to the question, but it's a little bit of a different paradigm thinking about that construct.
Yeah, but we know that there are different constructs that do need to be looked at. And I think that we're recognizing that more and more and addressing it more and more so that these social disparities can be equalized.
Definitely. And we all want to improve outcomes for our patients.
Thank you so much, Dr. Swanson. That was really a great start for our morning. And we will move on to our next speaker. Thanks. Next, I have the pleasure of introducing Charlotte Rosenfeld. Many of you have been referred or participated in conversations with our cancer risk and prevention program. Dr. Swanson just talked about some hereditary risks for cancer. We also are looking at gynecologic cancers on a more and more molecular level now. So we test tumors, and the tumors also have